For today's video, we will be discussing the pathophysiology and therapeutics indicated for gout. However, before we can begin talking about gout, we need to first briefly touch on the purine synthesis pathways because gout is really an imbalance of purine metabolism. There are two purine metabolic pathways. So the first is the de novo purine synthesis pathway, and this occurs in the liver. So this pathway begins with ribose 5-phosphate, or R5P, which is eventually converted to PRPP. And PRPP stands for 5-phosphoribosyl 1-pyrophosphate. Following a series of reactions, this will become IMP, or inosine monophosphate. And this is the purine precursor that can eventually become AMP or GMP and so on to form nucleic acids. And remember, this is occurring within the liver. So notably, this pathway requires more energy, and most extrahepatic tissues don't actually have the enzymatic machinery for this de novo pathway to occur. So instead, these extrahepatic tissues utilize the purine salvage pathway, which requires less energy to recycle nucleic acids. So in this purine salvage pathway, we are recycling partially broken down purine nucleotides. So these nucleic acids and nucleotides have been broken down to their mononucleotide versions, so either GMP or AMP. And remember that GMP and AMP can be converted to inosine monophosphate, or IMP, as well. These then become their nucleosides as either guanosine, inosine, or adenosine. And remember, adenosine deaminase, or ADA, can convert adenosine to inosine as well. These nucleosides are then lastly broken down to their nitrogenous bases. So guanine, hypoxanthine, and adenine. So at this level of the nitrogenous base is really where the salvage pathway begins. So we will start with guanine and hypoxanthine. These can actually be recycled back to their nucleotide version via the enzyme HGPRT. And this stands for hypoxanthine guanine phosphoribosyl transferase. And this process uses a PRPP molecule. Similarly, in this adenine arm, APRT, or adenine phosphoribosyl transferase, uses a molecule of PRPP to generate AMP. However, if there is an excess of these nitrogenous bases that do not need to be salvaged, then xanthine oxidase will come in and convert hypoxanthine to xanthine, and then eventually xanthine oxidase will convert it to uric acid, where it will then travel to the kidney for excretion. Now, guanine can also be converted to xanthine via a different enzyme, but then will be funneled through the same arm with xanthine oxidase to form uric acid. Now, there are two important things to note that will be key moving forward as we talk about these drugs and the mechanism of gout. So firstly, uric acid is filtered by the kidney, and it also undergoes tubular secretion, where uric acid will be secreted into the filtrate, promoting its clearance from the body, so ultimately lowering uric acid levels. But uric acid can also be reabsorbed from the filtrate back into the bloodstream. So this would increase uric acid levels. So this balance between filtration of uric acid, tubular secretion, and tubular reabsorption, all of these components combined determines what amount of uric acid is actually being cleared from the body. And the second important thing to note is under normal physiologic conditions, uric acid levels sit just below the concentration limit for solubility in most individuals. So moving on to the next slide. So keeping these two facts in mind, let's talk about when purine metabolism goes awry. Now, this can be from a number of causes that are genetic, dietary, pharmacologic, pathologic, and many other etiologies. But importantly, all of these generally lead to hyperuricemia, or high levels of uric acid in the blood. And we will use a high purine diet as an example. And these foods would include things like liver, seafood, and alcohol. And if you are exogenously supplying purines into the system, and once they are broken down to their nitrogenous base, there may be an excess that is not needed for purine salvage. These nitrogenous bases will continue to funnel through this pathway to be processed by xanthine oxidase, ultimately leading to high uric acid levels and this hyperuricemia. This uric acid level tips beyond that limit of solubility, leading to the formation of monosodium urate crystals. And these can deposit throughout the body. But these crystals generally deposit in distal joints first. And this is thought to be because the peripheral joints are cooler, promoting crystal precipitation. These crystals can trigger an immune response, leading to an inflammatory process resulting in a red, warm, swollen, painful joint. The recruitment of white blood cells to the site leads to the phagocytosis of these crystals, which can pierce the white blood cells so that their contents leak into the joint space, further promoting inflammation and chemotaxis of more white blood cells. Eventually, these attacks usually resolve spontaneously over a few days because these crystals are phagocytized, and this warmth and swelling from the inflammation favors crystal solubilization. This initial gout attack can eventually become episodic and finally chronic, leading to joint deformities and arthritis. Another important way we can breach this hyperuricemia cascade is through mechanisms that reduce uric acid clearance. This, for example, can be from CKD or chronic kidney disease, and it can also be from a number of drugs that inhibit urate tubular secretion into that filtrate, which, remember, promotes its clearance. So this leads to that familiar buildup of uric acid in the blood that may initiate that gout attack. So moving to the next slide. So while these attacks can resolve spontaneously, they can be extremely painful and debilitating for patients, which is why we have agents to help. So gout treatments will fall into two categories: agents used to treat acute gout attacks and agents used to prevent future attacks. So starting with the agents to treat gout attacks. The management of an acute attack of gout involves pharmacologic therapy aimed at reducing inflammation and pain. So as you can imagine, things like NSAIDs and corticosteroids are used to help with this. And indomethacin is the most commonly used NSAID for gout, but you can also see naproxen, Soldenac, or celecoxib used for this indication. Additionally, corticosteroids can be given either orally or intra-articularly to help with this inflammation and pain. Because these anti-inflammatory options and their mechanisms of action are not really specific for gout, we're just going to really mention them and move on to more gout-specific agents. Which brings us to colchicine. So colchicine is a more gout-specific anti-inflammatory agent that has a very unique mechanism of action. So it interrupts the polymerization of tubulin and microtubules, interfering with neutrophil migration to sites of crystal-induced inflammation. Colchicine also interferes with neutrophil and monocyte inflammasome complex, and this complex is responsible for the activation of interleukin-1 beta, or IL-1 beta. And IL-1 beta is a key cytokine involved in perpetuating the inflammation of gout, and colchicine will prevent this process. Unfortunately, colchicine comes with a lot of risk for toxicity because its effects on microtubules actually leads to cell cycle arrest, significantly affecting cells with a rapid turnover, like in the GI tract and in white blood cells. Because of the GI side effects and the risk for leukopenia, colchicine is avoided in most individuals that are at an increased risk of toxicity. So anyone that has a potential drug interaction, reduced renal or hepatic function will not see this agent. And its use at least high doses is typically limited to acute situations like this. Now, low doses of colchicine can be used prophylactically to prevent future gout attacks, but at least in this particular setting, the high doses are limited for the reasons we just discussed. Now we are going to segue into our sort of preventative prophylactic options. So moving on to the next slide. So now that we have employed one or a combination of these options to help alleviate the acute gout attack, let's discuss the agents that can help prevent future attacks. We'll start from the least to the most commonly used agents. So the first agent we will discuss is pegloticase. And its brand name is Krystexxa, and it is basically just a recombinant uricase. And this uricase has been modified so that it hangs around longer in the body. And what uricase does is it metabolizes uric acid to allantoin. And allantoin is a highly water-soluble metabolite of uric acid. And this conversion drops the uric acid level in the blood back into soluble limits, reducing the risk of crystallization in those peripheral joints. What's notable is humans do not make uricase, but other mammals do. But unfortunately, this agent is very expensive. It must be given IV because it is a protein and can cause severe allergic reactions. And this is why it is a third-line therapy. So moving up the ladder to our second-line agents on the next slide, which is probenecid. And probenecid is a uricosuric agent, which means it competitively inhibits the active tubular reabsorption of urate in the proximal renal tubule. So remember, this is how urate is reabsorbed from the filtrate back into the bloodstream. And by inhibiting this process, we are increasing the amount of uric acid that is cleared from the body, thereby reducing uric acid serum concentrations. So by lowering these blood concentrations below its solubility limits, probenecid decreases or prevents further risk of crystal deposition in those peripheral joints and reduces that chance of future gout attacks. So this agent does come with a number of drug interactions because of this inhibition of tubular reabsorption, which a lot of drugs use this process. There's also a significant risk of kidney stones associated with this agent, and it requires good renal function, which is why we find it as a second-line agent. So moving to the next slide. So our xanthine oxidase inhibitors, being either allopurinol or febuxostat, are our first-line agents for the prevention of gout. And they act by preventing this conversion of hypoxanthine to xanthine and xanthine to uric acid by inhibiting this enzyme. This backup of hypoxanthine and xanthine promotes their utilization for nucleotide and nucleic acid synthesis, resulting in increased nucleotide concentrations. So this increased nucleotide pool leads to feedback inhibition of the de novo purine synthesis pathway, so that we are really utilizing this buildup of hypoxanthine and not causing an increase in uric acid. And just as before, xanthine oxidase inhibitors drop uric acid levels to below their solubility limit, preventing the gout cascade. So because of cost, allopurinol is the primary xanthine oxidase inhibitor used in practice. However, there is a particular ADR, or adverse drug reaction, you should be aware of, since gout and allopurinol are pretty commonly seen. So if we go to the next slide. So allopurinol is generally started at relatively low doses and titrated up as needed because of this risk for allopurinol hypersensitivity syndrome, or AHS. And AHS manifestations include Stevens-Johnson syndrome and toxic epidermal necrolysis, which are life-threatening skin conditions, or it can manifest as a systemic disorder known as DRESS, which stands for drug reaction with eosinophilia and systemic symptoms, which can lead to multi-end organ damage. So from a pharmacogenetic perspective, the risk of AHS is significantly increased in patients that are positive for a particular HLA-B variant, which is shown here. So taking it back to immunology, HLA-B plays an important role in how the immune system recognizes and responds to pathogens. It is thought when allopurinol and its metabolites bind the protein encoded for by this particular HLA-B variant, it leads to a change in peptide presentation, activating self-reactive T cells. And it's thought that this triggers AHS more easily than other variants. The HLA-B5801 allele is most common among Asian subpopulations, notably in individuals of Korean, Han Chinese, and Thai descent. It is recommended that screening for this variant be performed on patients at higher risk due to race prior to prescribing allopurinol. And in the 2020 American College of Rheumatology guidelines, they now include African Americans in this high-risk group that would benefit from testing. So based on this testing and other factors, this is when febuxostat and probenecid may move into the picture as a more advantageous first-line agent. So this is a key example of how pharmacogenetics can influence clinical decisions and how you may counsel different patient populations on what to look for when initiating this therapy. So on to the next summary slide. So just to wrap up, all the underlying causes of gout generally lead to hyperuricemia beyond solubility limits, leading to crystal deposition and the inflammatory response. Agents indicated for gout either act to treat the acute attack by reducing inflammation and pain, or act to prevent future attacks by lowering uric acid levels. The most common agent used to prevent gout is allopurinol, but it comes with that risk of AHS, and particular populations will benefit from pharmacogenetic screenings and appropriate counseling.